are the approval of minutes for February 25th, 26th, and 27th. We're just about done now. Tomorrow's our last day for committee meetings. So hopefully you had a chance to review those. Do I have a motion to approve those minutes? Senator Gossage?
Madam Chair, I move that we approve the amendments of the minutes as submitted to us.
Thank you. Do I have a second? Senator Argabright seconds. Any conversation about those minutes? All right, if not, all those in favor say aye. Aye. Any opposed? No? Okay, the minutes are passed. I'm going to reopen the hearing on House Bill 2152. We didn't get a chance to finish some of the testimony on Thursday, and then we didn't get a chance to ask any in-depth questions of the presenters. So we have the state treasurers come back to answer any questions, and I appreciate that. We've got the bankers here, and the first person we had on our agenda was Kelly Vanzwell, but Kelly, you don't feel you need to add anything? Okay. Okay, just be available for questions. Then John Goodyear. John, would you like to come up to the podium and give us your testimony and introduce yourself?
Thank you, Madam Chair, members of the committee. Good morning. My name is John Goodyear, and I'm the General Counsel for the League of Kansas Municipalities. Grateful for the opportunity to speak in support of the process and the compromise that got us here today. Madam Chair, I can be brief. I could have got done on Friday. I can be incredibly brief. But you'll notice that in the House Committee there was significant opposition, and as Alex highlighted in his testimony on Thursday, that opposition has gone away, and that is largely due to the work that we've done on this bill to get to a good place that benefits everybody. And Madam Chair, I just want to speak in support of that compromise and the work that was done. I also want to highlight the work done by Amanda Stanley at the City of Topeka and by Kelly Vanzwell to write this bill. It's one thing to get everybody in a room and get to agreement, but then to have to commit that agreement to paper. They did tremendous work throughout a weekend, I think, just writing this bill. So it got to a good place. We support the process. We support the bill, and I can stand for questions at the appropriate time, Madam Chair.
Thank you. Thank you, John. So committee, I hope you had a little bit of time to review this from Thursday. Do you have any questions? And this is really the investment of public monies piece. Senator Fagg, being our banker on the committee, did you get your questions answered on Thursday? Was there anything more you wanted to ask?
Not at this point.
Okay, thank you very much. Committee, Senator Francisco, did you have a question?
No, Madam Chair, I think my understanding of this bill is it's really a choice of how we think best money can help Kansas. Can it help it through interest rates that someone's investing, or can it help through investments that banks can use? And so I think this really is an appropriate legislative decision, but I believe the proposal is a good one.
Thank you. Committee, any other questions? Senator Argabright.
Thank you, Madam Chair. I'm going to echo what the good senator just said. I appreciate the work that has gone into this, keeping money in Kansas, reinvesting in Kansas, so to speak. I think that's easy to vote on, and I appreciate all the work and the time that people put into it. And Kelly, thank you for writing Alex's notes so that presented himself well. Thank you, Madam Chair.
Thank you, Senator Argabright. Anyone else? Well, thank you so much. I don't know if there are any closing statements anybody wants to make. I think it was a wonderfully negotiated compromise opportunity for us. Thank you, Treasurer Johnson, for coming back and visiting with us. I think you got off the hook. No one has any more questions. So if that's it for House Bill 2152, no other questions, conversations, I will close the hearing on 2152. Thank you so much, bankers and municipalities and State Treasurer, for being here. Thank you so much. Okay, at this point, we will open the hearing on Senate Bill 284. Eileen, could you give us a quick brief?
Thank you, Madam Chair. Good morning, committee. Senate Bill 284 would enact the Defense of Drug Delivery Act to prohibit manufacturer interference relating to 340B drug distribution. Section 1 of the bill provides a citation to the act. Section 2 is the definitions section of the act. With Section 3 of the bill, we get into the more substantive provisions. Section 3 prohibits manufacturers, third-party logistics providers, repackagers, or any agent, contractor, or affiliate thereof from denying, restricting, prohibiting, discriminating against, or otherwise limiting the acquisition or delivery of a 340B drug to a covered entity or other location authorized by a covered entity to receive a 340B drug unless such receipt is prohibited by state or federal law. The section also prohibits the manufacturer from requiring a covered entity or authorized location to provide any health information, claims, or utilization data, purchasing, payment, or other information unless such information is voluntarily provided or is otherwise required to be provided pursuant to state or federal law. Section 4 authorizes the Attorney General to adopt rules and regulations necessary to implement and administer the provisions of the Act. This section also establishes the Defense of Drug Delivery Fund to be administered by the Attorney General and expended for the purpose of administration of the Act. Section 5 authorizes the Attorney General to administer oaths and affirmations, subpoena witnesses or matter, and collect evidence. This section authorizes civil penalties to be imposed on persons or entities that violate the provisions of Section 3 of the bill upon the written order of the Attorney General. Section 6 of the bill authorizes the board to investigate any complaint of a violation of Section 3 of the Act by a person or entity, registration or permitting requirements of the board. The board is authorized to impose discipline, suspension, or revocation of the license or permit of a person or entity upon a finding of a violation. And when I say board here, I'm referring to the Board of Pharmacy. Section 7 of the bill states that limited distribution of a drug required under 21 U.S.C. Section 35-1 shall not be considered a violation of the Act. This section also states that the provisions of Section 3 shall not be construed to prohibit a manufacturer from requiring certain health or other information or data if the information and data is required to be furnished under state and federal law. Section 8 of the bill states that the act shall not be construed or applied to be more lenient than any federal law as to any person or entity referenced or regulated by the act. The act shall not be construed to be in conflict with federal and related regulations or other law. Section 9 of the bill is a severability clause, and if enacted, the bill would become effective on July 1st of this year. And with that, Madam Chair, I can stand for questions.
Thank you, Eileen. Committee, do you have any questions of the reviser? Okay, very good. Thank you. Thank you, Eileen. So we have not a horribly large group, horribly maybe is not the right term, a significantly large group here today, but we did have to kind of limit your time to blocks of time, and you all were kind of given the opportunity to decide how long you were going to speak to, whether as a proponent or an opponent. We don't have any neutrals, so we have about a 15-minute block for each group, and then we have time for questions because we have to be out of here by about 25 after. So our first oral proponent, Michael Murphy. Senator Murphy, welcome to the committee.
Thank you, Chair Dietrich and members of the committee. A little bit of history on this. I'm not going to spend a lot of time because I want the other folks to have time to speak. But a year ago, I'd never even heard of the 340B drug program. And I got a phone call one night saying that an amendment had been brought to the budget on the Senate side and wondered if I would do it on the House side. And since I had no idea what I was bringing an amendment to, I needed to know whether I approved of it or not or whatever. So I did a lot of research and determined that it was something that I believed that was good for Kansas and good for my district, and so I did bring it. It was a pretty tough fight. There was a lot of opposition, but we did get it passed with 77 votes on the floor, so it was bipartisan. So I appreciated that. The underlying thing is that this was passed in Arkansas and had already been through the U.S. 8th Circuit Court of Appeals and had been upheld in that. very similar legislation. So this was something that I felt like was important for us to have, and so I ask you to support this, to 284, to help keep this available for Kansas. It's especially important for rural Kansas. And with that, I'll stand for questions. I do have to go to another committee, so if you have any questions, I'd appreciate it now.
Well, we'd be happy to accommodate your time. Does anybody have any questions of Senator Murphy at this point in time? If not, we know where you are. All right.
You know where to find me.
Thank you very much. Thank you for being here today. Okay. Our second proponent is Aaron Dunkel. Aaron, I know you're in here. Yep, there you are. Would you like to come up and introduce yourself? Welcome.
Thank you, Madam Chair, members of the committee. I'm Aaron Dunkel. I'm the Vice President for Regulatory and External Affairs of the, the Community Care Network of Kansas. We represent all the federally qualified health centers and health centers here in the state. Thanks for the opportunity to testify today in support of Senate Bill 284. Real quick on what we believe the bill does when we were working with Senator Murphy kind of developing this. There's two big things. One, it imposes limits on contract pharmacies that 340B covered entities can contract with. It basically tells manufacturers they can't tell us who we can contract with downstream in order to provide medications to our patients. Very similar to proviso that Senator Murphy mentioned from last year, but this has necessary changes in it that ensures that the AG can do what needs to be done as far as oversight and review and responsibility. The second piece, it restricts the pieces of data that manufacturers can ask from covered entities to things that are required under the 340B program at a national level. One of the things we have had happen over the last couple of years, well, there's two, both of them go back directly to the things we're trying to address in the bill. One, manufacturers trying to keep the covered entities from being able to contract with local pharmacy, with pharmacies other than one or two, and it kind of depended on manufacturer. So we're trying to limit that up and basically say, look, we should be able to contract with who we need to contract with in order to get medications in folks' hands. And then the second piece, there have been a number of companies that have asked for additional data as part of the requirement to be able to receive medications from their 340B program stock. And our take on that really is that that has, again, created administrative burden, has created situations where we just can't understand why they need some of the data. You know, there's certain places, there's a couple of them that have asked for things like diagnostic codes related to the medication, and we don't understand why you would need that to determine whether or not the prescription was appropriate for the program itself. In 340B, just real quick, for those of you who haven't really heard much about 340B, it was established in 1992 under the Veterans Health Care Act. The folks that can work under that as far as providers of these groups called covered entities, which usually are folks that have a large representation of underinsured and uninsured population that come to their doors. It's us, it's folks that are like disproportionate share hospitals, folks that deal a lot with a lot of uncompensated care. And really the intent was to stretch limited federal resources and provide two basic benefits. One, lower cost drugs for those that cannot afford them. So that's the piece where you actually see pass-through of those savings directly to the individual. And the second component was that program savings that can't come in through the program, that's a differential between what we pay for the drug under the 340B program and what's reimbursed for the drug from those with private insurance or private pay, is captured by those covered entities, and they're supposed to be reinvested in additional care. So additional lines of service, additional volume, being able to provide care to folks that otherwise wouldn't be available in the community. So that's what we do, that's what the bill does, and I'll stand for questions at the appropriate time.
Thank you very much. Appreciate that. I think we'll go through the rest of the proponents, if that's okay, and then ask questions. So second, I have Carrie Lutz. Is it Lutz or Lutz? Lutz, Holton Hospital. Welcome, Carrie.
Thank you, Madam Chair, for the opportunity to speak today on behalf of Senate Bill 284. I'm Carrie Lutz, as I just mispronounced my own
which
name.
is it?
It is Lutz. For the past 13 years, I've been CEO at Holton Community Hospital. And Holton Community Hospital is a critical access hospital in northeastern Kansas. Over this time, I've seen firsthand the immense value that programs like 340B have on rural healthcare organizations, particularly in small towns like Holton, where access to care is so critical. Our 340B partnership has really allowed us to work closely with local pharmacies to make sure that patients who have qualifying visits are ensured access to affordable medications. And just as important, those funds from the 340B program have allowed us to offer services such as Senior Life Solutions Program. I spoke about that in my written testimony. It's intensive outpatient group therapy. Without funding like that, we wouldn't be able to start up such essential programs in our community that really transform the lives of our elderly. However, when pharmaceutical companies mandate that covered entities could only choose one contract pharmacy, it really created challenges for us and small towns like Holton that have 2 local pharmacies. This policy has limited choices available to our patients, which ultimately impacts their ability to access medications that are affordable in a timely manner. The changes that pharmaceutical companies are making, often without thinking about the unique challenges in rural Kansas, have real consequences for our residents. Over the past 13 years, Holton Community Hospital has witnessed continued underpayment from vital services like Medicare and Medicaid. The underpayment has forced us to really rely on non-operating revenue streams like the 340B program. That really helps us bridge the gap, and unfortunately, as 340B funding has decreased in recent years, we've had to make difficult decisions. Recently, we've closed our home health and hospice programs, and we are looking at challenges in the future. We will be forced to look at additional cuts. We are also looking at requests to local taxpayer funding, which is a very unpopular decision. I'm here today as the face of a rural health hospital in Kansas to ask $0. It's not often that you're asked for $0. This bill is not tied to any state or federal dollars, only to ask for your support in passing Senate Bill 284. So thank you for the opportunity to speak, and I'm be available to answer any questions.
Thank you, Carrie Lutz. I just thought I'd throw that in there. Okay, Derek, and I really don't know how to pronounce your last name. Is it Peel? Peel. I was going to say Peel first.
I tell people it's like banana, banana peel.
Well, welcome.
Well, thank you, Chair Dietrich, and members of the committee for the opportunity to speak in favor of Senate Bill 284. My name is Derek Peel, and I am the Chief Pharmacy Officer at Salina Family Healthcare Center. Real quick, before I get started, I just wanted to note that my comments today complement my written testimony, but they're not a direct summary of it, just in case you're trying to follow along. What goes through your mind when you hear the word cancer? One of our patients likely had thousands of thoughts racing through her head when she was told in our local hospital she had cancer a few months ago. I know one of the thoughts she had was, how am I going to afford this? Because she had no insurance. Although the process was started to enroll her in Medicaid, a coverage determination was weeks to months away. Thanks to the 340B drug pricing program, she was able to access services at our clinic to take care of her in the meantime, including affording her medications at our pharmacy. 340B made the care she received possible. For over 30 years, 340B has been there to help safety net providers like us care for their patients in that way, helping patients afford their prescriptions and providing patients more services that are often not paid for in any other way. Unfortunately, in 2020, drug manufacturers began interfering with this by not allowing their drugs that were eligible to be filled through 340B to no longer go through the program if the prescription was sent to an outside pharmacy not directly owned by the 340B entity. By cutting off access to contract pharmacies in 340B, drug manufacturers have directly hurt patients and small local pharmacies. The most discouraging part of a pharmacist's job is when they receive a prescription that a patient cannot afford. Most pharmacies have very few options for helping patients in this all too common situation. At Salina Family, we have an arsenal of tools, all made possible because of 340B, but that is being threatened right now with the loss of access to contract pharmacies. Senate Bill 284 would restore the functionality of 340B and the access to community pharmacies that is so vital in a rural state like ours. A lot of times in life, you don't realize the value of something until it's gone, but I know the value of 340B right now, and I desperately don't want to lose it, or I don't know how we will continue to care for patients like the one mentioned at the beginning. Thank you again, and I'll look forward to answering any questions you may have.
Thank you. Thank you very much, Derek. Isaac Boone, is Isaac here? Hi, Isaac. Welcome to the committee. You want to
Thank
tell
you,
us
Madam
who
Chair.
you are?
Thank you, Madam Chair, for allowing me to join the committee this morning. My name is Isaac Boone. I have worked in the 340B world for over 11 years. I help oversee 340B programs for 42 critical access hospitals in the state of Kansas. This year, I purchased Eureka Pharmacy. This gives me a unique perspective, and I see firsthand how the 340B program profoundly impacts hospitals, pharmacists, communities, and patients. Here is one patient's testimony. My husband is completely blind and on Social Security, and even with Medicare, we struggle to afford medical expenses. Both of us are cancer survivors, but the treatments put a significant dent in our finances. For years, I relied on marketplace insurance, but when we lost the tax credit, it became too expensive. Without insurance, I couldn't afford a medication that significantly improves my digestive health after cancer treatments. It cost over $1,200 a month. Isaac found a way to provide the medication at a fraction of the cost, and now I can function much better. Small pharmacies in the 340B program are truly life-saving and life-changing for families like mine. I hear these stories each and every day. I want to share an example from my hometown, though I want to emphasize I am seeing similar situations across the state. Greenwood County Hospital, located in Eureka, Kansas, owns and operates a family practice clinic located 30 miles away in Howard, Kansas. Manufacturer restrictions on the 340B program essentially eliminated access to the 340B program for all patients seen in Howard. This has put immense strain on patients and the hospital. Julie Perkins, the owner of Batson Drug Store, located in Howard, also experienced the devastating effects of losing access to the 340B program. Without 340B, Julie has struggled to keep her doors open. The consequences continue to ripple through her community. Patients are less likely to get their medications due to cost. To access 340B savings, patients must drive 30 miles away to Eureka. So she no longer gets revenue from 340B, and now she is losing her patients too. Safety becomes a concern. Patients are now filling at multiple pharmacies, and pharmacists can only see part of a patient's medication profile, increasing the risk of contraindications or duplicate therapies. This defeats the very purpose of the 340B program. Patients who relied on it to now face increased risk must travel farther or simply go without their medications. If Eureka Pharmacy were to lose the 340B program, I am not sure we could keep our doors open. In Kansas alone, 10 pharmacies closed last year for similar reasons. What happens to the 70,000 prescriptions we fill each year? Where will these patients go? The nearest pharmacy to us is 30 miles away. Imagine driving 60 miles round trip to pick up an antibiotic for your child. This program is essential, not just for hospitals and pharmacies, but for the patients who depend on it. Please don't fall for the narrative that this program is being widely abused or creating immense profits for hospitals and pharmacies. The truth is a lifeline for underserved rural Kansas. Without it, access to health care will dwindle. Thank you, Madam Chair.
Thank you. Thank you, Isaac. Bryant Anderson. Bryant, you only got like 2 minutes. I'm sorry, you're the last one. So
I can comply.
you can blame the others. Okay.
I will cut out a section and we'll make it work.
Thank you.
Thank you, Madam Chair, and the members of the committee.
Welcome.
For the opportunity to speak before you today. Let me get my glasses here because I'm at that age where it doesn't work up close. I would like to address the misleading statements that the drug manufacturers make concerning the use of contract pharmacies. Number one, drug manufacturers claim contract pharmacies are causing the 340B program to expand exponentially. What they fail to share is that they are the main driver of this increase, not contract pharmacies. According to the Health and Human Services, drug manufacturers charge U.S. purchasers of drugs up to 1,000% more than they do purchasers in other countries. This results in larger 340B discounts, inflating the cost of the 340B program. Additionally, drug manufacturers voluntarily agreed to offer 340B prices to safety net providers in exchange for their overpriced drugs being covered under Medicare and Medicaid, giving them access to massive taxpayer-funded markets. Now, Big Pharma wants to renege on their agreement to provide 340B prices to rural Kansas safety net providers, but still maintain access to Medicare and Medicaid. I'm going to skip to number 3. Drug manufacturers claim the 340B program is exclusively federal, and any efforts by states to legislate are preempted. The intent of Congress was to address drug pricing while state laws govern delivery. HRSA reiterated this in 1996 when it stated that contract pharmacy arrangements are a matter of state law. Laws protecting drug delivery to contract pharmacies in the states of Arkansas, Louisiana, Mississippi, and Maryland have all been upheld by state and federal courts. In conclusion, I would like to refer you to the map in your packet, and I just blew this one up, but you have a smaller one. I'll get you a big one if you want it. But this map that I included with my testimony is showing the rural healthcare safety net that utilizes 388 contract pharmacies across Kansas to provide access to low-cost 340B drugs. Respectfully, committee members, this safety net is already fragile. Without SB 284's 340B contract pharmacy protections, it will collapse, leaving many vulnerable Kansans without low-cost medications and access to comprehensive health care services. That is why Senate Bill number 284 may be the most consequential bill this legislative session. Contract pharmacies are not the problem. They are the solution. Thank you for the opportunity to speak before you, and I will stand for questions at the appropriate time. Did I do okay? Okay, all right. I had some other good stuff, but hey, thank you, thank you.
Thank you, Madam Chair, and thank you, everyone, for attending the hearing today and the testimony. I had a question regarding one of the comments that was made that, well, you might have to drive 60 miles round trip for your antibiotic. And I just want some clarification on which drugs are covered under the 340B program and which aren't. Are all antibiotics on that, or what kind of medicines are we talking about?
One of the pharmacists can
yes.
speak to that.
Absolutely. Thank you for your question.
Would you introduce yourself one more time?
My name is Isaac Boone, and I am the owner of Eureka Pharmacy. That statement was in regard to if the pharmacy were to close without the 340B program. So it would be any antibiotic. So if a young child, you could no longer get it down the street. You would have to drive that 30 miles each way to get that antibiotic for your child.
So that's not related to the 340B and what's covered under 340B or not?
It could be, but that specific statement was only towards the fact that if the pharmacy closed without the 340B program.
Thank you, Madam Chair.
Senator Argabright?
Thank you, Madam Chair. I have a couple questions, if please. And I'm going to go to Aaron, please. And as you're coming up here, the first one, I'm on the middle of the third page, and part of the statement is the stated intent is that the data is needed to guarantee that prescriptions are not receiving duplicate rebates or discounts. So to me, that sounds transparency. Does this bill address transparency for that topic right there?
For that topic, it's our belief that the data that's already required through the 340B program from HRSA is adequate to be able to make those determinations. This is just additional data that the manufacturers decided on their own outside of the program to ask for in order to maintain the ability to access stock.
Okay. My second question, Madam Chair, is a pharmaceutical company, are they required to participate in this federal program, or is it voluntary? Can you explain that a little bit?
Yeah, very good question. And Brent kind of touched on this a little bit in his, but no, they are not required to participate in the program. It's a voluntary program. They participate in it largely so that they can have access to the Medicaid and Medicare Part B markets. So at any point, they could decide not to access those markets and not to participate in the 340B program.
Thank you, Madam Chair.
Committee, any other questions? Senator Francisco, we have about 4 minutes for questions.
Thank you, Madam Chair. So my question is for Ms. Lutz, if I'm pronouncing that correctly. So I appreciate your testimony and some of the other, examples, and certainly yours have been, helping individuals afford their medicines. But you talk about other things you're able to do through 340B savings, the Senior Life Program. So I'm trying to understand where the money is going. That's the savings. Is it going to reduce the cost of prescriptions, or are hospitals able to keep some of those funds and use it for, as you suggest, senior life solutions or behavioral health?
if I'm understanding your question correctly, and I am Carrie Lutz, we are able to utilize some of the savings. Besides patients benefiting from that, we are benefiting from the pass-through after a medication is purchased at a pharmaceutical company, one of the contracted companies. So there's savings that comes back to the hospitals as well. And we're using that savings then for helping and provide essential services. Does that answer your question or not?
I understand that. Can you tell me something about the split? How much of the savings goes towards the patients? How much goes towards hospitals?
I would have to get back to you on that.
Committee, Senator Gossage, a couple more minutes for questions.
Real quick question, and somebody from the hospital that testified. Fine. So I was a member of the 340B interim committee that we had for a full day a couple of years ago. One of the questions that I asked has yet to be answered, and it goes along with Senator Francisco's question, and that is, do the hospitals disclose this is how much money we made from the 340B program? Because what I keep hearing is less about helping low-income and uninsured, and more about hospitals could close if we don't have this 340B program, or pharmacies could close if we don't have the 340. So how much was made in this program? Do you know from your hospital?
I know only from my hospital's perspective. Prior to having to choose between two pharmacies, the savings was close to $1 million a year. Now the savings is around $500,000. And that can vary based upon when a prescription is refilled, how much of a certain prescription is utilized.
And when you're saying two pharmacies, that you are forced to select between two pharmacies because you don't have a pharmacy in-house. And which pharmacy did you choose?
Well, it's not that clear. So on each drug, each pharmaceutical company wants you to choose which pharmacy their drugs can be prescribed at. And so we look at where is the best savings, and on some we choose one and some we choose another.
And what are the
More
two?
often than not, we choose our local pharmacy.
Okay, so you have a local pharmacy.
Well,
and
our
then
local pharmacist that's attached to the hospital, it's not run by us, but we also have a Walmart pharmacy where probably half of our community utilizes.
Thank you.
A few seconds. Is it? Okay. Committee, we are going to move on to our oral opponent testimony, but I want to call your attention to written proponent in you've got some hard copies in your folder, and you've got several online. We probably have more than 75 pieces of testimony for you to take a look at, many from hospitals. So we'll begin now with the opponent. Remember, if you remember, I said there are no neutrals today. So oral opponent, our very first person is Caitlin, and is it Lucarello? And are you here? Caitlin, hi. Would you introduce yourself and pronounce your last name? And I'm going to set my timer. Thank you. If I can get it to stop. Okay.
It's one of my first times in committee that my name has been pronounced correctly. So my name is Caitlin Lucarello. I am a Deputy Vice President of State Policy for the Pharmaceutical Research and Manufacturers of America, or PhRMA, in the Rocky Mountain region. Thank you, Madam Chair and members of the committee, for having me here today in respectful opposition of this bill. From PhRMA's perspective, it is absolutely important that the 340B program truly works to serve safety net providers that help underserved communities in your state. We just respectfully disagree that this legislation will indeed continue to serve that purpose. The federal 340B program was established to help safety net entities access affordable drugs to treat their low-income and uninsured patients. However, due to weak oversight, the program has expanded substantially since 1992. And as a result of the growth, there has been covered entities using those revenues from the 340B program in ways that benefit them and under other middlemen in the program. As I mentioned, the program has grown dramatically, but corresponding growth in measures of patient benefit have not grown with the growth of the program. So for example, when we look at measures like charity care in Kansas, around 88% of hospitals are falling below the national average for provision of charity care to low-income patients. We've heard testimony today that there are very important programs propped up by the revenues of the 340B markups. And while some revenues from the program are indeed being used as they're intended to, there's also very substantial evidence that many are not. And in fact, revenues are being used for things like marketing, advertising, acquisition of practices in wealthier areas, all to generate more revenue from discounts in the program. And a severe lack of transparency in the program means it's almost impossible to trace where those 340B revenues are going. HRSA, the Health Resources Service Administration that oversees the program at the federal level, does audit covered entities. They conduct around 200 audits a year out of 55,000 covered entities in the United States. That's 1/3 of 1% of covered entities under 340B. In Kansas, it amounted to about 37 of your 91 entities being audited over a period of 10 years. That only 3 in the state have been audited twice in 10 years. And unfortunately, audit findings in HRSA, from HRSA, find a pretty high level of adverse determinations. In 2023, it was over 60% of the audits returned adverse findings. And that is really why we believe that significant reform to the program is needed at the federal level to ensure that it is benefiting patients and that there is transparency in the program. It's why we are part of a coalition seeking reforms to do just that at the federal level. I want to be very clear that this bill will worsen existing issues with the program by forcing manufacturers to ship drugs to an unlimited number of contract pharmacies and, by extension, offer 340B pricing at those pharmacies. These pharmacies have become a major revenue generator for middlemen, third-party administrators, data vendors, and others looking to make revenue off of the expanding program. And expanding the number of providers that, of contract pharmacies that providers can contract with in the state is just another example of how this program is growing, but unfortunately leaving patients behind because those pharmacies have no requirements to share those discounts directly with patients. And in fact, one study found that 340B discounts are only being shared with patients directly around 1.4% of the time. This bill, as you've heard, conflicts with federal 340B rules and enforcement and by restricting manufacturers' ability to place reasonable restrictions on 340B sales in the program. It is a federal program governed by federal law, and states do not have the authority to create new or conflicting requirements with that 340B statute. I also want to address the comment that was brought up that there are no costs here. I think it's interesting that there is not a fiscal note on this bill, and I would certainly implore you to talk to your budget office about that. There has been increasing data to show, particularly among self-insured employers like your state employee health plan, that there are indeed costs to this program. In part from lost rebate revenue, a 340B discounted drug cannot statutorily also receive a manufacturer rebate. And so self-insured employers must forego the rebates that they would typically make from a manufacturer on those medicines. In Utah, the state employee health program found that just a 10% increase in contract pharmacy usage among the program would result in $1.9 million loss annually to the program. That's a pretty conservative estimate. In Tennessee, the state found that there would be an annual impact of $7.4 million to the state employee health plan and $1.5 million to local self-insured government health plans. And it's not just foregone rebates. The program is also shown to increase the costs between 340B hospitals and non-340B hospitals. North Carolina's treasurer conducted an audit of outpatient oncology medicines prescribed to state employee health plans, and they found that there was about an 85% markup between a 340B provider versus a non-340B provider on those medicines, which equated to an average profit on each medicine of about $6,000 of taxpayer money for the state employee health program. So very significant, and would certainly encourage you to look a little bit more into the costs there. I want to say that we are very much...
You're not going to leave any time for anybody else.
Okay, yeah, we're very much committed to safeguarding the 340B program, but I would ask that you please consider a no vote today. Thank you.
Thank you. The other thing I would mention is we do have a fiscal note. It's from the Office of the Division of the Budget, and it is in our folder. Do you want me to pass this over to you so you can see it?
Yeah, I apologize. When I checked this morning, I did not see a fiscal note.
We just got it this morning.
Oh, okay. Thank you.
Okay, all right, thank you. Our second opponent is Brian Hannon. Brian, are you here? You're on WebEx. Can you hear us? Do you see him, Brennan? Brian?
Yes, can you hear me? Good morning, can you hear me okay?
Brian, we cannot hear you, could you?
Okay, let me try this one more time.
There you are.
Can you hear me now?
Okay,
Okay.
we hear you now.
My apologies.
That's
My
all right.
apologies, Chair. Thank you, Chair Dietrich. My apologies for not being in Topeka this morning. I fortunately could not to make it, but thank you for accommodating me for remote testimony. I will be brief. My name is Brian Hannon. I am the State Government Relations Director for the Healthcare Distribution Alliance, which is the National Trade Association for Pharmaceutical Wholesale Distributors. I'll briefly summarize our concerns with the bill as it's introduced and simply ask the committee to consider an amendment that would remove wholesale distributors from the bill. I do want to thank Senator Murphy so far for his willingness to engage in these conversations with us and be receptive to our concerns. And I'm hopeful that moving forward, we can find a path that would move us to neutral on the bill. Simply put, wholesale distributors are the logistics experts in the supply chain. That our members ensure that pharmacies and hospital shelves are stocked with the medicines that patients need, including for more than 3,000 locations across Kansas. Distributors, however, play no role in setting the price of the product, and they do not determine or control access to the 340B price determination. Instead, distributors work under contract with manufacturers, and therefore any stipulation regarding the delivery of a 340B product are determined by the manufacturer and not the distributor. So it is our view that including distributors in Senate Bill 284 would hold the wholesale distributor accountable for the decisions of a manufacturer. But the brief second point I'll make that I think is really important, another reason we're concerned about inclusion of distributors is we think their inclusion in the bill potentially conflicts with federal drug enforcement agency regulations that restrict how distributors handle certain controlled substances. And it could also contradict the obligations that wholesale distributors have under the National Opioid Injunctive Relief Settlement Agreement, which Kansas is party to. So we feel this could result in our members being placed in an untenable position of either complying with federal requirements and the National Opioid Settlement Agreement or with a state law. I'm happy to say that we've worked with other states to amend distributors out of these types of bills, and I'm hopeful that we can do the same in Kansas. And for these reasons, we respectfully ask that you remove distributors from the bill and hopefully would move us to a neutral position on the underlying bill. With that, I'm happy to stand for any questions at the appropriate time. Thank you, Chairman.
Thank you, Brian. Appreciate that. Dr. Kevin Mills, you are next, and you have about 3 minutes. Sorry.
Thank you, Madam Chair. I'll be very brief. I'll be like 30 seconds. Also, I'm going to take mercy on the committee with an easy to pronounce last name. My name is Kevin Mills. I am the president and CEO of Ad Astra Bio and BioKansas, two sister associations that represent the biotechnology industries in the state of Kansas. We're the trade association. We represent the biosciences research industry. So I appreciate the opportunity to share our respectful opposition to this legislation, and I'll be very brief as to the reasons why. There's two simple reasons. First is, although we're a trade association, we really represent the people of the state of Kansas and believe deeply in the intent of the 340B program, which is to provide affordable access to prescription medications for for patients. But unfortunately, since its inception, those funds have become increasingly diverted, and patients are not realizing the savings that are really intended for them. And we think that the expansion that will be allowed under this legislation is going to just exacerbate that problem. Those funds, while not always diverted away from patients, it's an undeniable fact that they are. And those savings not being realized by patients ultimately net increases the cost of drugs and puts an affordability burden on patients. The second reason that we're in opposition is that increased pricing also puts an incredible financial and fiscal burden on employers. There are about 1,600 life sciences associated companies in the state of Kansas, many of whom are self-insured companies. And the burden that the 340B, the diversion of those 340B funds puts onto those companies prevents them from reinvesting in their companies, prevents them from growing their businesses, prevents them from hiring into what are generally considered good jobs in the state. And so because of the financial burdens on the industry, particularly sort of small and mid-sized employers, and the financial burdens on patients, we respectfully oppose this opposition. And with that, I will stand for questions at the right time.
Thank you very much. William Wilk. William, can you do 4?
Good morning, Madam Chair, members of the committee. My name is William Wilkes, Senior Director of Government Affairs for the Kansas Chamber of Commerce. I'll keep this very brief, and I just want to talk about the potential implications of the cost impact on this bill. So as you heard, a study conducted by Akiva estimated that foregone rebates on prescriptions filled with 340B pricing increased Kansas commercial employer cost by over $69 million on plans in 2023. On Kansas state and local government plans, the cost increase was $13 million. If Senate Bill 284 were to become law, it is estimated this bill would increase cost on Kansas commercial employers by an additional $21.6 million and $4.2 million on the Kansas state and local government plans. In closing, I just want to say that this legislation is an unnecessary mandate on the pharmaceutical manufacturers involving a federal program that could be subject to change with the new administration. With that, Madam Chair, I want to thank you for allowing us to testify in opposition today, and I'm happy to stand for questions.
Gosh, you get a gold star. That was like really quick. Thank you. Thank you. I appreciate that. So committee, we have about 5 minutes of time for questions of the opponents. So does anybody have any questions of the folks who just finished testifying? Senator Gossage, or I'm sorry, San Francisco. I didn't turn far enough, did I? So sorry.
Not a problem. So my question is with regard to the bill and its just limiting, not having any limits, and wondering if the opponents would be comfortable with a limit either in location from the prescribing individual or hospital, or within a county area, or with a different number other than just unlimited.
Who would like to speak to that? Welcome.
Thank you.
Caitlin.
Thank you, Senator, for your question. Pharma, like many trade organizations, we represent a number of members, 30 members. All of them have different opinions on what an appropriate number or limit might look like. I can't say today what we could agree to. I can tell you that we would be more than willing to have conversations with you about the bill and potential kind of impacts and our members' concerns. And, again, we believe that this is a federal program. Any additional changes to contract pharmacies, which are not in statute in the program, bleeds over into those concerns, but it certainly does not prevent us from being very willing to have a conversation with you after.
So I appreciate that because do you know that there are companies that are limiting their distribution to just one pharmacy?
So that is proprietary information. I don't know the details of individual companies' limitations. I do know that companies are placing limitations on contract pharmacies, and it is largely, as I mentioned, to control growth and to address concerns of abuse within the program, yes.
Senator Fagg. Question.
Thank you, Madam Chair, and Thank you for your presentation, Deputy Vice President. So I was looking at the fiscal note, and I think you was the one that brought something up on that. It says the Kansas Board of Pharmacy indicates that 284 would have a fiscal effect of about $220,000. And it said the board anticipates that complaints, investigation, and enforcement activity would be significant in the first 3 to 5 years. Can you give me an example of what kind of complaints you think we would see with something like that?
Thank you for your question. I imagine that it would have to do with the part of the bill that would permit there to be investigation into complaints, particularly investigations with the Board of Pharmacy helping. There is a piece in statute that allows for investigations by the Attorney General, and I believe the Board of Pharmacy has some ability to participate in those investigations under the bill.
Can you give me an example of that? You know, what you would envision with that type of thing? I was trying to clarify a little bit more for somebody that doesn't deal in pharmacy.
Yeah, I imagine that it would be related to expanding to an unlimited number of contract pharmacies and manufacturer limits that were brought up by Senator Francisco. I think that would probably be where the majority of those complaints come from. I'll just remind you that in federal statute, there is no mention of contract pharmacies. Pharma is required to, by federal statute, provide 340B discounts to a number of covered entities. I believe it's 14 different types of covered entities, including critical access hospitals, sole community hospitals, and we continue to provide discounts to those providers. The question here is pertaining to the requirement to provide discounts to contract pharmacies, which are not mentioned in statute.
Thank you.
Senator Gossage, and then Senator Rose, and then we'll run out of time at that point.
Thank you, Madam Chair. So when I checked the federal government, they said that hospitals are not required to disclose which patients receive the drugs, how much the savings are, nor how the resale profits are used. So when we talk about transparency, I think this is something that could be improved on the federal level to make sure the program is working as it was originally intended to work. Do you know how many, because we know a small number initially when 340B was set up, it was to help more inner city where they'd have more uninsured, low-income folks. Do you know how many hospitals were initially and how many are now?
Yes, thank you, Senator. It's a great question, and we'd certainly agree with adding additional transparency at the federal level into those things. The first year that the program was implemented, 45 hospitals participated in the program, to answer your question directly.
And do you know how many hospitals now?
I don't know individual hospitals. I know of those 14 categories of covered entities, there are 55,000 providers participating.
Thank you. Thank you, Madam Chair.
Thank you. Senator Rose?
Thank you, Madam Chair. Does the typical patient who qualifies for 340B have prescription drug coverage? And second, real quick, what changes do you anticipate the Trump administration making?
Thank you for your question, Senator. There is no typical 340B patient. There is no definition of 340B patient in statute. A 340B patient could be you or I when we go to a 340B hospital. There is no income qualification or qualification based on insurance type. We are optimistic that we will see movement at the federal level. Senator Cassidy has said that he will carry a bill addressing many of the concerns that you've heard from the opponents of the bill today. We haven't seen a bill yet, but we are encouraged with Senator Cassidy's desire to move legislation forward and the current administration that will be able to make progress at the federal level.
Thank you. Thank you so much, everyone. I really appreciate the conversation that we've had today and the testimony. You've answered our questions. You've done a wonderful job of explaining this to us, both sides. At this point, I will close the hearing on Senate Bill 284. Committee, I want to remind you that tomorrow we are going to work 5 bills, and we'll send you an email on this, but 2152, 2128, 2334, 2086, and today's Bill 284. So we will, and tomorrow's the last day we can meet, so we will get that accomplished. I'm going to hold you hostage. Thank you so much. Meeting adjourned.